Okay, shall we start?
Inshallah.
Okay, Bismillah ar-Rahman ar-Rahim. Alhamdulillah, Rabbil Alameen, sallallahu alayhi wa sallam, baraka ala Muhammad, wa ala alihi wa sahbihi ajma'in. Welcome you all for the continuous medical education for mainly targeted to the primary healthcare teams and other also colleagues in the other specialty. And today we are going to start a series of sessions on headache, which is sometimes cause you headache while you are looking at your, seeing your clients and evaluating your clients. When a lot of questions comes to you, what's the diagnosis? What are the red flags? Should I refer to other specialty, care? Do I need to refer them to the orthopedic? Is it cervical headache or the other causes of headache? And a lot of questions. So we thought to start this series with the association with the Oman Neurology Society, Oman Epilepsy Society, and the Oman Family Medicine Society, with the local coordination of the Primary Healthcare Dakhlya Committee. So we are glad today to have with us our colleague, Dr. Abdullah Al-Asmi, who is Associate Professor in Sultan Qaboos University. He's also senior consultant neurologist, and he's also chairperson of the Oman Neurology Society and the Oman Epilepsy Society. Our talk, as usual, will have like around 30 minutes of presentation, and then we'll have like Q&As and question and answers. You can start putting your questions through the Q&A icon, and also you can use the chat icon if you have any, like you have difficulty in the voice, or you have like some queries about the technical issues of the Zoom itself. And also, if you want to introduce yourself to in the chat area, you can put your name also in the chat area. So this is the the brief about the Zoom. By the end of the session, you will have like a certificate, which is like category 2 by Oman Medical Specialty Board, which is 0.5. But I think by the end, we'll get like 2 hours of the CME. I'll not go longer, and we welcome you all, and welcome also Dr. Abdullah Al-Asmi, and the ground is yours. Please, Dr. Abdullah.
Thank you, Dr. Zahir, for this initiative. Yourself and your team definitely would like to thank the Oman Family Medicine Society, and as well as Dakhlya Primary Healthcare Committee for having this initiative, which I think it's very, very important. And we had agreed that we're going to come up with basically 4 presentations related to headaches. And this will be the first one, and it will focus mainly on migraine. The second lecture will be on other primary headaches, which are also common and may be encountered by family physicians. A third presentation will be on secondary headaches, and then a 4th presentation will be on headaches in pediatric population. We are looking forward for this interaction. As requested by Dr. Zahir, to make the presentation more interactive, I would be posting some questions during the presentation, and I would expect some response from the audience as well. So let us start by trying to learn more about our audience today. And if you don't mind, if you just tell me your specialty, please, you can vote, whether you are a family doctor, a general practitioner, and so on.
Yeah, I'm starting getting the voice, Dr. Abdullah.
Very good, very good. So maybe we'll give them a little bit of time, maybe for a few more seconds, and then we will get the poll.
Great.
Okay, good.
Now, okay. Now we got almost like 66 responses, 83 responses. I think we'll end the poll. Okay, we're getting now 90% responses. I think we'll end it now. Okay. Okay, Dr. Abdullah, you can see the result now.
Very good. So we have good representation from the family doctors and general practitioners, which are very good. We have also people from emergency medicine, some internists, and some neurologists, and few from other specialties. Maybe very good. We also have some medical students as well. Great. Okay, so let us start. So the question is basically, how common is headache encountered at primary healthcare setting? There are many studies looking at this particular issue. I've picked this particular one study, which was conducted in European cities, basically Germany as well as Netherlands, where they have looked at about more than 10,000 consultations, and they try to find out how common headache was one as a presenting symptoms. And what they found in this particular study, that about 5% of all general practice consultations were patients presenting with headaches. I could think that dangerous causes of headaches were very rare. However, still, sometimes a general practitioner may face with an underlying etiology of headache, which is dangerous and require immediate attention. So in your opinion, maybe we'll ask this question, in your opinion, as a general practitioner in a primary healthcare setting, what really the physician would take as an action to make a diagnosis of a headache? Pick up two most common action a general physician will take when he is faced with a patient having a headache.
Now we're getting the responses, Doctor. Already.
Good.
Yeah.
Okay, so if you are there, maybe we can see what are the responses. What is the two most common action are taken by a physician in a primary healthcare setting? Yeah, that's what is expected. It's basically a good history and a focused examination, general and neurological exam. Another one would be a follow-up consultation, which is also very reasonable in a primary healthcare setting. And then there are a few others. That's very good. Okay. Then let us go to the next question. And this is addressing what a physician is going to do in terms of treatment, again, in a primary healthcare setting for a patient presenting with a headache. Maybe we can ask the participant.
That is already launched.
Yeah, so would write a drug prescription, would refer the patient, would have a follow-up consultation, would recommend hospitalization or physical therapy? What would be the two most common actions?
You can put more than one answer. The option here.
So we wanted at least two most common options.
So you can put 2 clicks.
Yeah. Okay, Zahir, how are you doing? Yes, this is also excellent. This is what you would expect from the physician at primary healthcare setting, would possibly give a symptomatic treatment for the patient's headache and would arrange a follow-up consultation. And this is very, very important to make sure basically his thinking process is right. And in few occasions will refer the patient either to a specialist or recommend a physical therapy. Great. Excellent. So what did the study found? Basically, in terms of headache etiologies, 60% of the headache etiologies were related to basically a headache which is part of an upper respiratory infection, or patients would have a primary headaches, migraine, the most common, or he may complain with issues related to cervical spondylosis, neck pain, musculoskeletal pain. And in this study, and most probably that would reflect also our practice here in Oman. In terms of the actions taken by the physician to diagnose headache, as you have picked up, basically good history, focused physical examination, and follow-up consultation was the two most common actions taken. And then, if required, in some patients would be laboratory investigations and referrals. And in terms of treatment, again, also this study had shown that patients were given drug prescriptions and also a follow-up consultation, which again, it seems the audience, that's their usual practice. So this is great. So let us move. I'm going to present a case scenario, a patient which we commonly see in our clinic. This is again a specialty clinic or a neurology clinic. This particular patient had seen, who is in her 40s, a mother of 4 children, and basically she comes in with long-standing history of headaches. How she described her headaches, which started in the early 20s, unilateral, build-up, throbbing, attacks of moderate to severe, and they may last for a few hours up to a day, and they are associated with nausea and at times even vomiting. And during the attack, she does not tolerate lights and noise, and she reports no symptoms before the onset of her headache. Initially, she would used to get headaches 1 to 3 attacks every few months and would improve with paracetamol or non-steroidal anti-inflammatory medication. However, over the years, her attacks became more frequent and of a longer duration. And specifically over the last 1 year or so, she reports almost daily headaches with episodes of severe attacks in between. She feels depressed and cannot cope with her activity of daily living. She's currently taking paracetamol, almost 4 to 8 tablets daily for many months. She also takes PRN non-steroidals, PRN zolmitriptan, and had tried multiple medication for prophylaxis in the past with no success. Clinically, she looks depressed, overweight. Her blood pressure was 145/80 and had no focal neurological signs. She had, in addition, some multiple tender points over her neck and shoulder region. So, based on her clinical presentation and the physical findings, I would like you to list all types of headaches our patients is suffering from. And you can pick up more than one if deemed so. Okay, Zahir, maybe you can put in the poll. So we have so we have migraine with aura, migraine without aura, chronic migraine, tension type headaches, medication overuse headache. Okay, Zahir.
Okay, we are reaching now 75% responses. Okay.
Yeah. So some said migraine with aura, and in this particular patient, she had no symptoms preceding her migraine. So she did not have migraine with aura. She did have migraine without aura, definitely. And she is now getting into what we call chronic migraine. Tension type headaches, very difficult to say. In patients with chronic migraine, they may also in addition have tension type headaches. But in her case, it was primarily chronic migraine. And definitely over the last 1 year, she qualified for medication overuse headache. Very good. Okay. So our patient basically had migraine without aura. She had chronic migraine, and she had medication overuse headache. Good. So basically, we hope over the coming 20, 30 minutes, we're going to cover and review basic pathophysiology of migraine, diagnostic criteria, burden of diseases and global impact, and also an overview of management and what we can do for these patients. So when it comes to pathophysiology, I think before we start, we have a question. So Zahid, why we don't put the question? So this question is related to pathophysiology, and it's basically which of the following is a consequence of activation of the trigeminal-vascular system? So Zahir, if you put it, is it a release of vasoactive neuropeptides, vasodilatation, perivascular inflammation, and anyway, there are a few things missing, Zahir, in this particular question. Few more answers.
Shall I check?
But I assume they can pick as many as possible, or only one?
Fine.
Okay.
I think we can give them some time.
Sure.
Okay.
I think it's enough because I need to make a comment on this particular question.
Okay.
Yes.
We reached 75% of the people.
Okay.
I think we'll end it.
Sure.
Okay.
Okay. So this particular question, unfortunately, E was not included in the response, and that was the correct answer. And so I don't blame the audience on this particular question. I mean, all these happen when trigeminal vascular system get activated. So when it comes to pathophysiology, there are a lot of things we have learned about pathophysiology of migraines. However, there are still also more to be learned. We clearly now know migraine has a number of phases. We identify a prodrome, which may take minutes, hours to even days sometimes, where a patient's become irritable, feeling depressed, yawning, and so on. And then in patient with migraine with aura, they may have symptoms of aura which may last 5 to 60 minutes. And then the acute phase of the headache, if untreated, may last for hours to up to 3 days. And then the post-drome, which also may last for a day to 2 days. And for each of these phases, there are now better understanding of the physiological changes. If you take an example, for example, in patients with migraine aura, now we know that cortical spreading depression do cause an aura, and this basically wave, which is here represented by red, move forward from the posterior aspect of the brain forward, and it causes generalized depolarization followed by repolarization, and this repolarization is really associated with significant reduction in cerebral blood flow, but it does not follow any particular territory as far as the blood supply is concerned. And this has been documented by various functional neuroimaging in patients with migraine and aura. And when it comes to the trigeminovascular system, which is very, very important in patients with migraine, it basically consists of the trigeminal nucleus. And as you know, it extends basically the whole brainstem and up to even the upper portion of the cervical spinal cord. And in addition to the nucleus itself, we have the trigeminal ganglion or the dorsal root ganglion and the branches of the trigeminal nerve, and in particular the V1, which also supply the pain-sensitive structures, the blood vessels within the cranium, the dura, the meninges, as well as the skin and various structures in the face. In addition, the trigeminovascular system receive an input from cortex, hypothalamus, and the hypothalamus as well. Now, when an acute migraine is initiated, and this is also thought because of some dysfunction similar to the cortical spreading depression, it's called cortical sensory depression or dysfunction, which initiate the process, and that basically leads to activation of the hypothalamus and subsequently activation of the trigeminal nucleus, which leads to the release of a number of vasoactive neuropeptides, and one in particular is what's called CGRP, or calcitonin gene-related peptide. And this particular substance or neuropeptide causes a number of things. One of them is basically vasodilatation of the blood vessels within the meninges. It causes meningeal mast cell degranulation and extravasation of the plasma, or what is known as neurogenic inflammation. In addition, the CGRP causes and stimulate the nociceptive pain fibers around the trigeminal ganglia and fiber endings, and that also leads to further stimulation of the trigeminal nucleus. And in addition, CGRP has been shown to cause central sensitization. Now, you would understand that a lot of focus have been paid, especially the last few years, trying to control the release of the CGRP. And this pathophysiological changes would explain also some of the symptoms the patients may experience in relation to meningeal irritation like phonophobia, photophobia, worsening of headaches with coughing and sneezing and so on and so on. That's the reason it's very important for those patients to control those symptoms before they can get worse. So this is a very brief description of the pathophysiology of migraine, and it's very important to know some of these basics, as most of the medications which we are giving patients, especially the specific one to treat migraine, are targeting the CGRP neuropeptide. So when it comes to diagnostic criteria, and I think questions are, so maybe we can put in the question before we talk about the diagnostic criteria. And this is to do on, basically it says, which of the following is typical of the clinical presentation of migraine headache? And you need to choose basically one best answer. Okay, Zahir.
Okay, we're getting almost like 40%, I think.
Okay, we'll give them a little bit more time then.
Yeah.
You know, the answers are a little bit long, so they need to read.
Yeah.
Yeah.
Okay, we reach 75, 80% of responses. Okay, I think we'll stop here.
Very good.
Okay.
Okay. So the most commonly picked answer is headache pain is typical unilateral. Great. Okay. It seems we have, yeah, I agree with that answer. Good. So let us look at the diagnostic criteria. And basically, we are following the International Classification of Headache Disorder when we are faced with a patient who is having a headache. This particular classification, they have their recent edition is a third edition, and it was published in 2018. And for the sake of time, we're going to just cover 3 diagnostic criteria, but audience are welcome to read more about other diagnostic criteria in the guideline. So we have migraine without aura, migraine with aura, and chronic migraine. So let's start with migraine without aura. So A, at least 5 attacks fulfilling criteria B and D. So this is very important. And sometimes at the primary healthcare setting, a patient may come to you after the first attack of a migraine. You cannot diagnose migraine. You would suspect it. You need a minimum of 5 attacks. And these 5 attacks have to fulfill criteria B and D. So what's B? B is an attack lasting 4 to 72 hours when untreated or unsuccessfully treated. And what is C is headache, which has at least 2 of the following features. Unilateral location, and that was one of the things in the response in the question. It has a pulsatile, so it's throbbing in nature, and it's moderate to severe, and it's aggravating by physical activity or avoidance. So again, you may need to dig into the history of the patient. And D, during the attack of the headache, at least one of the following: nausea and or vomiting, photophobia and phonophobia. So at least one of those 2. Most of the patients with migraine would have all of them. And again, we need to make sure we are not missing anything else. And basically, especially when it comes to concern related to secondary causes of headaches. And that would basically, if you take a good history and a focused clinical exam, most of the time you're not going to miss it. So patient with migraine with aura, which is less frequent compared to migraine without aura. So A, at least 2 attacks fulfilling criteria B and C. So B, 1 more of the following fully reversible aura symptoms. And these could be visual, sensory, speech and/or language, motor, brainstem. So brainstem patients may have vertiginous sensation and so on. And retina patient may have reduced vision when they have retinal visual auras. C, at least 3 of the following 6 features. 1, at least 1 aura symptoms spread gradually over 5 minutes. So usually the symptoms would last at least 5 minutes. 2 or more aura symptoms occur in succession. So a patient may have more than 1 aura. 3, each individual aura symptoms last 5 to 60 minutes. 4, at least 1 aura symptoms is unilateral, not bilateral. So 1 eye, for example, but not both eyes. 5, at least 1 aura symptoms is positive. Most of the migraine symptoms, migraine aura symptoms are positive. 6, the aura is accompanied or followed within 60 minutes by headache. And again, make sure there's nothing else would explain it. So these are the features of migraine with aura. For patients with chronic migraine, like our patient, which we presented earlier, so A, headache, could be tension type and or migraine-like on equal or more than 15 days per month for more than 3 months and fulfilling criteria B and C. So the headache should be really almost daily or at least 15 days per month. And it's not just 1 month, minimum 3 months. Our patient had these symptoms for almost a year. And B, occurring in a patient who has had at least 5 attacks fulfilling criteria B and D for migraine without aura and or criteria B and C. So you need to make a diagnosis. The patient should have a diagnosis, an underlying diagnosis of migraine, whether migraine with aura or migraine without aura. And this is something very important when you take a history. Sometimes the patients would come in with chronic headache or chronic daily headaches. So you may need to go back for a year or 2 in the history and find out what was actually the initial symptoms of these patients. And C, on more than or equal 8 days per month for more than 3 months, fulfilling any of the following. 1, criteria C and D for migraine without aura, criteria B and C for migraine with aura. So basically, as I said again, the patient, in addition to these daily headaches, if they should have in between some of their attacks typical of migraine, whether migraine with aura or migraine without aura. And this is important to differentiate it from other underlying etiologies of chronic headaches. Could be just tension type headaches, for example, or medication overuse headaches and so on. So again, I would really strongly recommend to keep the International Classification of Headaches handy. It's easily accessible, freely accessible. You can put it in your desktop and or your smartphone and basically consult it every time you are faced with a patient who have any types of headache. So let us move now and talk briefly about migraine burden. And we have a question related to migraine burdened. And this question, it says migraine affect more than something percentage of global population. So pick up one answer, please.
Dr. Abdullah, the answers are very nearby.
No, 1, 3, 5, 7, 10, not at all.
Good.
Yeah. So how are we doing there? We're done, or?
Just we are reaching now 80% of the. Shall we post the answer?
Yeah.
Okay.
So let us get a feeling of the audience. What do they think? So they think almost 40%. They thought around 5%, and maybe this is based on the initial study which we presented, which was done in Europe. And to be honest with you, I had expected to be a little bit higher than 5%. Okay, good. So let us continue with the presentation. So globally, it's more common than 5%. It's more than 10% of the population are estimated to suffer from migraine, unfortunately. And if you look at just headache disorder is also very common. 47% of the population are suffering from some sort of headache, and 10% are basically related to migraine. And this is not specific to any region, I mean, all over the world, and unfortunately. And migraine, very unfortunate, affects the population's age group between 15 to 49 years. I mean, this is the highly productive group of people, and it's a very disabling illness. Unfortunately, female do suffer more than male in a range of 2 to 3 times. And migraine is very disabling, and in fact, it ranks number 16 as a cause of total DALYs. DALYs is basically the sum of the years of life lost due to premature mortality, and we know migraine does not cause, it's not a fatal disease. So most of the years lost is because of disability. And that's a lot. And in fact, it's more disabling than asthma or even Alzheimer's disease. So let us now move to management, which will be, would spend more time discussing management. And there are general principles, which are very, very important, I think, to understand when you are faced with a patient who has migraine. And one is to establish a diagnosis, and this is very important. Very important, the patient knows that he has migraine. And then we need to educate the patient about the condition and what's available in terms of treatment, and maybe provide him with some materials to read, and there are so many available about it, because this is very important. Otherwise, the patient will end up shopping different places and so on. And another thing is to establish a realistic patient expectation. You know, we don't promise that we're going to cure and the patient will have zero headaches. That's what we aim. But, you know, so we would tell them that we can help you in reducing the frequency of your headaches. We can help you in reducing the severity of headaches. But again, maybe we will not be able to reach to 0%. So if somebody has headaches 3 times a week, you know, if you get it to 1 time a week, that's better than a 50% reduction in headache frequency and maybe even severity. And very important to get the patients involved in actively in managing their problem. So in terms of management, we have basically many things to offer for patients. There is the non-pharmacological, there is the acute treatment for the headache attack, the preventive therapy, and neuromodulation. Now, when it comes to non-pharmacological, when you take the history, you're going to find out that, you know, maybe there are a number of triggers for the patient's headache. But I would suggest we should not really focus a lot in trying to, you know, make sure the patients avoid these triggers, because sometimes it's almost impossible. And also the patient sometimes may feel a little bit guilt about it. But however, I would suggest we should focus more into improvements of the lifestyle of the patient. This is very important. Regular exercises, better sleep hygiene, healthy diet. These are very, very important and would play a major role in helping these patients to manage their migraine. We can teach them or advise them to try and get some help with stress management, maybe some relaxation technique, even the simple ones. And also, if it's possible, maybe join some groups for meditation and yoga. All these things are very, very important and play a major role in managing these patients. And I would say better than basically giving them guest medication. And many of these patients, their headaches would improve significantly by following the non-pharmacological treatments for their migraines. Now, in terms of pharmacological therapy, as we mentioned earlier, we have treatment for acute attacks and also for to try and prevent the attacks. And before we discuss this, I have two questions related to this. We'll start the first question, Zahir. And this is related to acute therapy. So if you can put the question, please. And pick up one option only. So the following medications are commonly used to abort acute migraine attack, except. Okay, Zahir.
I think I need to wait some to reach 70%.
Okay.
Okay. Fine. We are launching the result.
Okay. So, okay, variable answers. So again, this is except, and we're going to talk more about it. The reason I put this particular question, I would like the audience to avoid to give patients opioids to treat acute migraines. Try, and this is the last resort. Avoid using opioids. Anything else is okay. So the second question is to do with preventive therapy and the side effects, which I think very important to be aware of the common side effects of some of the preventive therapy you may initiate. So what is the correct answer here in terms of pairing the medication which is with known common side effect? And again, here one option only. Okay.
I'll give some time, Doctor. We are reaching 60%.
Okay, we'll give them a little bit of time because they need to think about it. It's not, yeah, it's okay. We'll give them a little bit of time.
Great.
Good. Okay. Okay, so again, here we have a number of questions, number of response. So amitriptyline, it's very well known. One of its side effects is drowsiness, and in fact helps sleeping. And that's the reason we're giving it at night. And usually it's once daily, and we give it at night. So it does not cause insomnia, it causes sleepiness and drowsiness. And many patients, in fact, they may complain about that. And usually we ask them to take it a little bit early in the evening and not to delay taking it in the middle of the night or late at night. Sodium valproate, it's an anticonvulsant. One of its issues usually cause hepatic toxicity rather than renal. Again, that's very rare. Methotrexate, it's not a very common medication we use, to be honest with you. And the reason is because of its side effects, because it does cause pulmonary fibrosis. That's the reason many people now, they stop using it because we have so many other options. Propranolol, again, it seems most of you know, we use it in patients who have thyrotoxicosis and so on, because it causes bradycardia. So it's the opposite. It doesn't cause tachycardia, it causes bradycardia. And topiramate, one of its preferable side effect, especially in women, is it reduces weight. So when you have an overweight patient and you want to give them preventive therapy, topiramate will be a good choice. We don't give it specifically to reduce weight, but a patient, in addition of getting his headache relieved, his weight also will be reduced. So the answer was C. Good. So I put this question for people to give chance for them to interact and maybe strengthen some important information. Okay, so let us move in terms of treatment of acute migraine attack. If the patient has mild to moderate attack, I think the usual medication we have are very reasonable, and some of these are available without even a prescription. A cocktail of medications, combination of acetaminophen, aspirin, caffeine, and so on would be great. Or just use one of the non-steroidals. I like naproxen and ibuprofen, again, these are available. However, when the migraine attack is moderate to severe, then we may require a specific anti-migraine medication. And under this group will be the triptans. The triptans are basically serotonin agonists, and they have a very high affinity to the 5-HT1B receptor, which are basically found at the trigeminal nerve endings, basically in the blood vessels and so on. And they cause vasoconstriction. And they try to prevent the release of the CGRD and also reduce the neurogenic inflammation. And this is one of the reasons we don't and avoid giving triptans to patients who have ischemic heart disease. We try and avoid giving them a triptan. In fact, it's contraindicated on those group of patients. A number of these medications available, and they are available and they are in the market for so many years now. I'm not sure if all of them are available in Oman, but the one which are commonly prescribed here are the one I put in the boxes. So we have naratriptan, zumatriptan, and zolmitriptan. Some of them come in a different formulation. For example, zumatriptan, if a patient has severe nausea and vomiting, then they can use intranasally instead of oral, for example, or even subcutaneous. And in patients who have very long or prolonged headache for hours or up to a day, then maybe zolmitriptan will be a better option. And some of these medications can be used more than once in a day, and they are very useful for patients who get moderate to severe attacks of migraines. Now, in addition, I would suggest, because these patients would have nausea and some of them even vomiting, is to take metoclopramide. Again, it depends. If it's at home, then orally, and if it's too bad, then if they come to the emergency room or to the health center, they can be given intravenously. In some occasions, we may give dexamethasone, but that's rarely, and I would leave it for patients with very severe attack or patient with status migrainous. There are other medications which nowadays less and less we use them on a daily basis. They are glutamines, and partly because of the potential side effects. So DHE is one of them, but again, rarely we use them, as well as lidocaine. So mainly for mild to moderate attack, non-steroidal, paracetamol. For moderate to severe, one of the triptan. Now, it's very important to educate the patient, to inform them that as soon as they feel that the headaches start, they should take the medication, the abortive therapy. They should not wait until the headache gets really severe. And if they wait, unfortunately, many times medication will not work. And many of these patients, they will end up coming to the emergency room or to the health center for parenteral medication. So I would always tell the patient to carry these medications with them, and when they feel the headaches, to take it. And if the time and the place permit, they even, if possible, to go in a dark, quiet room and take a nap for 20 minutes would definitely help. So it's very important to take the medication as early as possible and to try, if possible, to rest for 20, 30 minutes would make a big difference. Now, when it comes to preventive therapy, again, not every single patient who has migraine would require preventive therapy. There are some guidelines, and usually we start preventive therapy for those patients who have more than 4 headaches attacks per month, or they have more than 8 headache days, because some patients may have 1 attack which may last 3 days. And those patients would qualify for preventive therapy, or the attacks are very severe despite taking acute therapy appropriately, or they cannot tolerate acute therapy, or it's contraindicated. For example, in patients who have ischemic heart disease and they cannot take triptan, say, for example. So some of those patients we may have to give them, or overuse of acute medication. And also, some patients, they just don't want to get any migraine attack because it's disabling, it's unpredictable, it's so inconvenient. So some of them, they would request for prophylaxis. Or some patients would have certain types of migraine, like hemiplegic migraine, say, for example, and so on. And those patients, we usually put them on prophylaxis. So we have a number of options. The common one is beta blockers, and I think most of you are familiar with, commonly used. Beta blockers, as you know, we cannot use it in patients who are asthmatic, patients with bradycardia, COPDs. Commonly, we use propranolol or atenolol. Anticonvulsant, as I mentioned earlier, topiramate is commonly used. We usually start with small dose and build it up. Most of the patient will be okay for 50 to 100 milligram a day. It's very important, again, for topiramate to use it, especially in patients who are overweight. And it's important also to avoid it in patients who have kidney stones. So this is very important to ask for history of kidney stone, because rarely it may cause kidney stone. Commonly, these patients would complain of paresthesia when they take topiramate, and it's related to hypokalemia. So what we usually advise them is if they feel paresthesia, is basically to take food which is rich in potassium, like kiwis, bananas, and so on. For sodium valproate, it's also a good medication. However, avoid it in patients who are overweight. It can cause weight gain, and some patients don't like that. And as mentioned earlier, rarely we need to monitor their LFTs. Rarely it can cause hepatotoxicity. Antidepressants, I mean, would be a good alternatives in patients who have also depressive symptoms. And it's very common in migraine patients to have also depression. So commonly we use amitriptyline. Again, we have to be careful, especially in a little bit older population. We need to get an ECG and make sure there's no issues with the QT interval, and that's very important. Avoid it in patients who have glaucoma, male patient with prostatic, benign prostatic hypertrophy. It may cause an issues. And as I mentioned earlier, it causes sleepiness, drowsiness. So it has to be taken at night, and it's usually once a day. We start with 10 milligram, and usually most of the patient will do well with 25. Rarely we go to 50 milligram once a day. Another medication, it's an alternative, it's also a good option, is venlafaxine or Effexor. It's one of the SNRI group, and again, we give it sometimes patients who have depression, patients who cannot tolerate amitriptyline, and we start with 37.5 milligram, and we build it. Usually 75 milligram once a day is enough. Now, the other medications which are less used, one of them is candesartan. It's getting more popular among headache specialists, and as you know, this is an ARB medication used to treat hypertension. And again, usually we start with smaller dose, and then we build up the dose. So these are the common medications used to prevent as a preventive therapy. And again,
Abdullah, I think we are almost reaching 1 hour.
Okay. So I'm gonna speed up, inshallah.
Thank you, Doctor.
So basically, general principles. Very important when you start preventive therapy, you titrate the medication. You start slowly and build up. And it's very important, don't switch unless the patient develops side effects. You need to reach maximum dose before you say the medication had failed. And in rare occasions, you may want to combine therapy. In patients who failed preventive therapy, you may want to try Botox, especially patients with chronic migraine. And then there are other options like physical therapy, acupuncture, and nerve blocks. So briefly, what's new in the treatment of migraine, and it's to do with a better understanding of the pathophysiology of migraine, especially the importance of the CGRP. And there are a number of medications now used for acute treatment, which are targeting the CGRP receptor antagonists. They are antagonizing the receptor, and they are under the group of what's called GPANs. There are a number of these molecules, and I don't think we have them yet in our own market here. For preventive therapy, there are now a number of monoclonal antibodies which are against CGRP, and they are used once a month, and they are really effective when a patient had failed the usual preventive therapy. Now, another medication which is also new, used as abortive therapy, and it's one of the triptan, but this particular one is targeting 5-HT1, which is not present in the blood vessels. So it's mainly in the nerve endings and in the central nervous system. And so that would be a good alternative for those patients who cannot take regular triptans. In terms of neuromodulation, these are devices available in the market, but require prescription and can be useful in patients who cannot take medication, for example, during pregnancy or because of other comorbidities, like non-invasive vagus nerve stimulation. We have transcranial magnetic stimulation, supraorbital nerve stimulation, and so on. I think I'm gonna basically stop here. I want to talk about status migrainous. However, I'm gonna skip this particular because of the time limitation. And basically, I think in terms of diagnosing migraine, it's easy if you're gonna follow the criteria. It's very important when approach the management of these patients, we approach it in a holistic way. Medical therapy, pharmacological therapy play, I would say, maybe a minor role. Very important to stress on the non-pharmacological therapy. And when a patient had an acute attack, very important they take their medication as early as possible. And if the patient requires preventive therapy, then don't delay it. Initiate the preventive therapy. Thank you, and I'm going to stop here and happy to answer any questions. Thank you.
Thank you, Dr. Abdullah, for the nice presentation and talk, and also feedback from the attendees. And we got like 8 questions. If you can put it, Doctor, you can click on the Q&As. If you'd like to see it. And we can, there's one request to have a lecture. I mean, your presentation can be shared with the attendees.
Sure.
Okay, fine. We'll share it with the email listed with us, inshallah. And Dr. Sumaira, she's asking if symptoms lasted more than 70 hours and not improving. I mean, so do you need, is it one of the indication of prophylaxis for the migraine?
No, so one of the things which I wanted to talk about is status migrainous. And so again, we need to differentiate, a patient who is having continuous migrainous attack, which lasts more than 72 hours, he's getting into status migrainous. And those patients definitely has to be managed in either an emergency room or in a day center, for example. And they would require parenteral medication like zomatriptan, for example, dexamethasone, sodium valproate, magnesium sulfate, and so on, hydration. And in fact, some of those patients, if they don't improve, we may even have to admit them to give them continuous infusions of DHE or sodium valproate or even lidocaine. So they go into status migrainous. Now, if their attacks are recurrent, then you definitely may consider give them prophylaxis, definitely. But again, not during the acute attack, that you have to treat the acute attack. It will be just a long-term plan.
Thank you, Doctor. There's a question about can aura phase overlap with like acute headache phase? Like
yes. Aura phase can overlap. And again, when it comes to the definition, we're talking about 5 minutes to 60 minutes. But that's very, very well known. It can happen, yes.
Yeah. And Dr. Mukhtar is asking about how to differentiate an aura with, especially the speech aura, with the TIA. There's like something to differentiate.
Yeah. So that's difficult sometimes. And again, it's very important, as I mentioned initially, especially when a patient comes in initially with a new onset of headache and is not diagnosed to have migraine, it becomes more difficult. But if the patient is known to have migraine with aura, then it becomes less difficult. So sometimes it's difficult. I mean, you know, there are occasions where we even have to, we had thrombolized patients who have migraine aura because it was difficult to differentiate, and their aura lasted more than 5 minutes for sure. I mean, an hour or 40 minutes, and they showed up in the emergency within time. But again, good history and exam will definitely help in such patients, but sometimes difficult.
And so this question will lead us to the other question on the chat. As per pathophysiology of migraine, does the patient with migraine are at higher risk to have stroke more than the others?
Yeah, they are, especially migraine with aura, but the percentage is not very high, and also the percentage go higher if the patient has other risk factors. For example, in a female patient who has migraine with aura and also taking, for example, the oral contraceptive pills, and overweight or have other comorbidities. So definitely they are at higher risk, but the risk is very small. And again, we didn't have enough time, but it's considered, I mean, it's by its own a topic. It's complicated migraine, where some patients may have either continuous auras, may last for days, or they would have infarction. And in the diagnostic criteria, each one of these have its own diagnostic criteria to fulfill.
Yeah, it looks like the question goes around the stroke itself. So I mean, the question in hemiplegic migraine, is there an urgent need of imaging to rule out like infarction, stroke? What's the most useful tool to differentiate it at primary health care?
Yeah, so good news, you know, hemiplegic migraine is very rare. In our own practice, we are following maybe 1 or 2 patients. So it's not very, very common. Initial presentation for the first time, definitely patients would require workup to make sure that we are not missing another cause of their hemiplegia. However, if the history is known, clearly documented, then there is no need every time a patient presents with hemiplegic migraine would require imaging. And in fact, many of these patients would not even bother to go to see a doctor because they know their condition. However, usually most of these patients, we put them on prophylaxis. Usually we use verapamil, and their attacks are very well controlled. So first time, definitely yes. After that, you don't need.
Yeah. And there's a question, Doctor, about the use of beta blockers as a prophylaxis in migraine with aura. And I mean, there's some controversy. Can you just, discuss this issue?
Yeah. Use of, so I don't know what are the controversy. I mean, it's beta blockers are very commonly used. Definitely, I'm sure when we talked about pediatric migraine in pediatric population, this would be one of the common prophylactic medication to use. We just need to make sure that the patient don't have any contraindication to use them. We start slowly and build it up. I commonly use propranolol compared to the other beta blockers. When a patient comes to us as a specialist, most of the time would initiate something else, like topiramate, for example, or an antidepressant. However, beta blocker are still used, and definitely they are effective if patient tolerate. Definitely.
Yeah. Thank you, Doctor. I mean, the question about is it recorded? This webinar is recorded, and we'll look if it is suitable for the sharing, inshallah, after the end of the session. The other question about the migrainous infarct, is there like if you can explain briefly about it?
Yeah, again, when we talked about the pathophysiology of migraine, especially migraine with aura, and we talked about the cortical spreading depression, which is followed by the significant reduction in the cerebral blood flow, and rarely in some of these patients they would develop infarction. And again, this is very very rare, and we should not really get worried about. We rarely see it. There are other reasons for patients to have infarction, and usually when these patients come to us, we always exclude other causes before we label them as migraine, as infarction due to migraine. So we should not, again, as a primary healthcare setting, we should not worry about it a lot, and we should not also make the patient worry about it, because it rarely occurs. However, we have to be a little bit careful when you are seeing patients with, especially migraine with aura, and they are overweight, female taking as well oral contraceptive pills, or smoking, then we have to be a little bit concerned. And those patients, we should advise them to reduce their weight and maybe think about alternative methods of their oral contraceptive pills.
Yeah, thank you. About a question about the role of the nutraceuticals in migraine, like riboflavin, magnesium, and the coenzyme.
Yeah. So these are dietary supplements. They are being used. In pregnancy, unfortunately, we don't have a lot of options for abortive or even preventive therapy. And we sometimes try riboflavin and on higher doses in some of these patients. So they are used. They are almost have no side effects. It's not an issue to be, given. Unfortunately, their effectiveness is questionable, but have been tried, like anything else. Because unfortunately, there are certain situations we cannot give medication, especially during pregnancy. The good thing about pregnancy, in general, especially after the patient, the female patient passed the first trimester, their headaches, their migraine headaches, usually gets better. So if in case they get attacks, usually we ask them to try other things, including dietary supplements, physical therapy, and neuromodulation, sometimes helpful.
Yeah, thank you, Doctor. Like a practical question here from Dr. Ahmed about if the patient comes with the migraine criteria and at the primary health care, to establish a diagnosis, do they need to refer them to like a neurologist, or to confirm the diagnosis, or just like to fit the criteria and start the management?
Yeah. I think you guys are very well trained, and you can definitely manage those patients comfortably. Good history, good physical examination, and again, follow these basic guidelines. If the attacks are not frequent, you just educate them on how to manage the acute attacks. If they are frequent, you initiate. I would suggest you referral to the specialist. When you failed maybe the first line of preventive therapy, or patients have atypical symptoms, I would refer. Otherwise, I think a family physician would comfortably manage most of migraine patients and does not really require referral to neurologist, at least not at this stage. As you know, Dr. Zahir, very few neurologists available in the country. And I think if they are spared to manage more complex cases, it will be a good idea. Unfortunately, and this is nothing special about Oman, this is globally, and people have looked at this. many of these patients with migraine, many of them, even though they qualified for preventive therapy, they are not given preventive therapy. And it's becoming a problem. The issue is they're going to transfer, like the patient I presented, from episodic migraine to chronic daily headaches because of poorly treated migraine. So really a primary healthcare physician, a family doctor can play a major role to try and prevent that. And the disability, the magnitude of disability of migraine is unbelievable. I mean, it's not just the attack of the headache, which may last an hour or two, is before and after, the inconvenient for the patient. The attacks can be very, very severe. So I think a family physician and activities like this, where we share knowledge, educate each other, and so on, are very useful, very useful.
Yeah, thank you. And this will take us to the, I mean, these CMEs are, usually aiming to empower, primary healthcare, team in the recognition and management. And also, this is based also in like asthmatic, the use of prophylactic and asthmatic and other, chronic condition need to be like, updated to the best. And then the question about the maximum dose of propranolol to be used as a prophylaxis.
Yeah. Again, it's in the presentation, but what I would recommend, we start slowly and go up. I have seen big doses. I personally, I would go around 40 BID or so, but you can go even higher doses if the patient is tolerating it. The issue with this medication, again, we are talking about a population. Many of them are, athletics, or they have good physique, and many of these patients may have to start with lowish heart rate. So many of these patients may develop bradycardia when you go higher doses. But the trick is we start very low and build it up slowly as tolerated.
Okay. Then we'll have like quick question and answer, doctor, about the risk of epilepsy in migraine. Do you have higher risk?
Well, it can coexist, especially in patients who have occipital lobe migraine, being well described. It can coexist, yes.
Yeah. What about the indication of nerve stimulation device use? And is it available in Oman?
I'm not aware of it. I know you require a prescription. I know in some of the other neighboring countries available. Definitely not in, I'm not aware that it's available in a government. I don't do private, so I don't know if it's available. But it's been tried, and there are clinical trials showing that it does reduce the frequency of headaches. Unfortunately, these devices are a little bit expensive, so many patients may not be able to afford.
The role of keto diet, sometimes we see some patients with keto diet, they have improved of headache frequencies, etc. on this issue. Do you see it also in the migraine?
Yeah, good question. I'm not really familiar with this, so I cannot comment. I don't know if it's going to make your headache worse or not. So I don't know. I don't have any experience on it.
Some they do go better, but I think it's worth to do a study. Mohammed, you can start, Dr. Rizvi, a study on this issue for a publication.
Maybe keto diet would reduce the weight of the patient. The patient will feel better. Their sleep pattern would improve, and then overall, it may work.
Yeah, could be sleep apnea and other issues.
Yeah, definitely. Now we have to be careful. Fasting by itself can induce migraine, and we have some experience, especially during Ramadan, for the first day or two. Some of these patients may have their headaches worse because of different reasons. So again, one has to be careful with that. But I think the keto diet may work in the other way around, as non-pharmacological treatment.
Yeah. What about the role of high flow oxygen? Any role for
Yeah,
it?
I think maybe the next week lecture, we're going to talk about, Professor Aaron is going to talk about cluster headaches, and it has more role in cluster headache rather than migraine.
Yeah, I mean, when to refer a patient with migraine, to ER, emergency, department. What are the indications to think of some indication to?
Again, I think only when a patient has status migrainous.
Okay.
If the patient has status migrainous, then you do refer, and this is persistent headache for more than 72 hours. Or a patient who had failed acute therapy available in your setup. Some primary health centers have better setup than others. If they fail the acute therapy available in your setup, it's a good idea you send them to the emergency room. And then if you are concerned, patient has additional stuff, focal neurological deficit, atypical headache, which is not the usual headache he's having, then it's worth to get a second opinion.
Which brings us to the red flags in migraine, like a typical presentation and
So I sort of intentionally removed the slide on red flags because I thought Dr. Sulaiman Al-Hatim, you're going to talk about secondary causes of headaches. And we have the whole hour to discuss this. But very, very, very important, patients who, when you take the history, make sure this is the usual migraine headaches. If the patient tells you this is different, then you have to be careful. Acute onset, very severe, not the usual. Migraine is not acute. Migraine usually build up. Even over a few minutes. If something sudden, you have to question that. Somebody who comes in with other stuff, for example, fever, meningeal signs, significant like neck stiffness, focal signs, then you have to be careful. Fever, those are the red flags. Otherwise,
I think Dr. Abdullah will make this question as an appetizer for the second presentation.
Yeah, second and the third presentation, definitely, Dr. Zahir.
Inshallah, you're invited.
It's a package. It's a package.
Yes, thank you, Doctor. I think we are having almost now. We are getting more and more questions. I think we can get like 3 questions, and the idea, I think we can share the questions with you. Either Doctor, you can record it, and we are going to add it to the what's called it, to the video recording, or we can send like Q&As session. Okay, we'll take some few questions about the, let's go for another, we'll choose some of the question here. About what the safest prophylaxis in pregnancy, migraine, prophylaxis in pregnancy, which is the safest?
Yeah, that's tough. Unfortunately, most of the medication, either class C or D, and some of them even X. So we don't have a lot of options. And as I said, the good news that these patients, if they can manage to pass the first trimester, their migraine headache will get better during the rest of the pregnancy. What we had tried is, as I mentioned earlier, riboflavin. You can give in higher dose, like 100 milligram twice a day. You try other treatments like manipulation, physical therapy, acupuncture. Those sort of things may help. Some patients, even nerve blocks. Some of those definitely would improve their headaches using those. But unfortunately, most of the conventional medications we cannot use during pregnancy, and it is an issue, unfortunately. I mean, we sometimes face to give patient topiramate, but again, you have to be very careful. Data are not enough there. In the past, they used to give magnesium. However, that's now we know it's contraindicated, so we should not give magnesium during pregnancy. It has been shown to have a teratogenic effect. and we stopped practicing that, but it used to be given in the past. So very few options, unfortunately.
Yeah, and the question goes up to the use of ECG and the CT scan. I think in the diagnosis, or to rule out.
No, we don't need. If you have very good history, you don't need to do imaging. Good history, good physical exam, you are very comfortable, no need to do neuroimaging.
Yeah, and the use of, beta blockers and asthmatics.
No.
Okay.
No.
Fine. There is the use of Botox. Is it?
Yeah. So Botox, it's something becoming more and more popular. Only in patients who failed prophylaxis, preventive therapy. Usually we try more than one, and it's very useful for patients with chronic migraine. So those patients would require to be referred first to a neurologist, and then when we evaluate them and we try medications, if they fail, then we refer them to either a headache specialist or a neurologist who is trained to give Botox injection.
Yeah. One of the colleagues, Dr. Mukhtar, says one of his patients feels sensation of coldness in scalp and weird unilateral sensation in the head after taking naratriptan. And recurrence of migraine attacks comes more with increased intensity, and he refused to take it. What he should do on such case? Do you need to, change the type of medication, or what do you advise on that?
Yeah, so very unfortunate. Sometimes many patients, they don't tolerate triptans, and some of them, they get even chest tightness and so on. But nothing to worry about. If you reassure them, then they would take it. What normally I would do is you can switch. So if they are not comfortable with naratriptan, you can try zolmitriptan or zumatriptan, for example, as an alternative. And again, remember the triptans we are using mainly for moderate to severe attacks of migraine. Now, the newer triptans, I don't think they are yet registered in Oman, but I'm sure they will be coming soon, and they would have less side effects.
Yeah, a question about AC. ACs inhibitor.
Yeah,
and,
ARBs. Or like lisinopril and so on. Yeah. So the main one is the one people have used it. I personally have no experience on them. I don't think they are that effective. Apart from the angiotensin 2 receptor blockers, apparently it's gaining some popularity among headache specialists. I don't have any personal experience myself using it, but it is an option. And when I have attended a number of these CMEs, it seems people are talking about it. But lisinopril, I think it's least effective. Yeah. I would not start a patient on lisinopril.
Any experience with hijama rule in headache? Migraine?
You guys are the expert.
Okay.
When Dr. Abdullah Al-Mahrazi.
I think we'll look at the pain management colleagues on this issue. What about mesenteric headache?
Yes, it's abdominal migraine or mesenteric. It's common in pediatric, and I would leave this. It's rarely in adults. I would leave this to talk number 4 when we talk about migraine in pediatric population, because there are specific presentations in pediatric, including abdominal migraines and others, even encephalopathy as a presentation.
Yeah. What about some ladies, they have more migraine on their period time?
Yeah.
Do you advise anything or to add like antidepressant?
So this is by itself is a talk, and in fact I wanted to talk about it, but the time is limited. Yeah. It is a problem, definitely, and again it needs to be really defined very well, because sometimes it comes during menses, sometimes it comes during just the mid-cycle, and so on. So there are a number of ways one could deal with this. Sometimes what you can do is you can give them, for example, non-steroidal or some of the triptans, like a day or two before the menses, and you continue on daily basis for 4 or 5 days. It does help. Some patients may try some hormonal therapy, like estradiol, that's gel or patch, and that also may help. Some patients, you may want to give them a short course of prophylaxis just for a few days if it's very predictable. But really we need to take a good history and find out when do they get these attacks. Sometimes you are successful and sometimes you are not, unfortunately.
Yeah. And the question about temporal, temporal epilepsy and the migraine.
Yeah, so the common association between migraine and occipital, it's more common than temporal lobe epilepsy, but we have to remember both conditions are very common. Migraine is common. Temporal lobe epilepsy is one of the most common types of focal epilepsy. So you may end up having a patient both, but especially in pediatrics, being described occipital lobe epilepsies and migraines to coexist. So what happens is when you have a patient who has epilepsy and has migraine, it will be a good idea to give them medications which can deal with both conditions, like topiramate or sodium valproate.
Do you need to do sometimes cervical, X-ray to rule out cervical spondylosis or cervical cause of headache? With some resistant cases of
So straightforward cases, typical, no. However, if patients have cervicogenic headaches, for example, or their migraines mainly on the occipital region, it's worth doing. And again, we may have sometimes patients with cervical spondylosis by itself could make their headache worse. And in fact, and there are some interest with physiotherapists that manipulation of the cervical spine in patients who have migraine improved significantly their migraine attacks. And I know even here in Oman, there are some physiotherapists who are interested in this subject, and we refer patients to them, and they do some manipulation of their necks, and their headaches improved quite a bit.
They can do also dry needling and other approaches also.
Absolutely, yes.
Yeah.
Yes.
They use about diclofenac injection for the acute headache.
Yeah. So
okay.
it's an option, definitely. But again, I think it's very important we educate the patient. We educate the patient on when they feel the headaches coming, they should take abortive therapy as soon as possible, as early as possible. Many times, unfortunately, the patient don't do that, and they end up coming to see the doctor, and the doctor have no choice but to give them something parenteral. We try and avoid this, and you guys know better than us about the potential complications of parenteral non-steroidals and so on. Try and avoid where possible, but very unfortunate that, again, in patients who have severe headaches, if some of the triptans available in the primary healthcare setting, it will be a good option subcutaneously, for example. Again, this is something you guys as a family physician, you may want to discuss with the authorities to give you in cases like these. Triptans will be definitely better than non-steroidal when it's moderate to severe attacks.
Yeah. Then we're heading for the final two questions, Doctor, about the use of IV caffeine.
IV caffeine?
Yeah, someone asked this question. Is there an IV caffeine for
Yeah. I mean, sometimes being used, and I remember one of my first slides in the abortive therapy, caffeine was part of the cocktail. I personally don't have any personal experience with the use as intravenous, but had been used. But alone by itself, based on my reading and so on, I did not see it anywhere.
Yeah.
It can be used in combination for mild to moderate headaches as part of a cocktail. Yes.
Yeah, thank you. The question about how to manage, client with medication overuse.
Yeah. So this is again a huge topic. It requires by itself maybe a full presentation. Unfortunately, very common. It's one of the differential diagnoses of chronic daily headaches or chronic migraine. So again, we need to make the diagnosis to start with.
Dr. Abdullah, you can hear us? Okay, it looks like Dr. Abdullah's connection is have been disrupted.
So I'll give them Hello?
Yes, please repeat the answer, Doctor.
Okay, from the beginning?
Yeah, because it was disruptive, the internet.
Oh, okay. So what we need to do is basically we need first to come up with a diagnosis based on the diagnostic criteria, and then we need to stop abruptly the medication overuse, the medication which is basically causing this problem. With few exceptions, if the patient is taking opioids or benzos and things like that, you may want to taper them. We provide them with alternatives. So the alternatives could be one of the non-steroidals, ibuprofen or naproxen, for example, for their acute attacks. In some occasions, we may have to use a short course of dexamethasone or prednisolone. Some patients may help. In rare occasions, especially if required detoxification, we may have to admit those patients. But again, if we manage the migraines early and appropriate, we will not get into this. And this is very important. So counseling of the patient, appropriate use of acute medication, initiate preventive therapy as early as possible, you would avoid these issues. And when you are stuck, when you have patients with MOH, the medication overuse, headaches, you may have to refer them to a specialist to help you manage those patients.
Yeah, thank you, Dr. Abdullah. I think it was very fruitful, and we managed to keep almost like 75%. Or almost like by the end of your presentation, everybody was around. I think it was very fruitful presentation, and it is interactive also. And the question have been, raising a lot of practical, questions to be used by our colleague in primary healthcare. I would like to express my thanks to you, Dr. Abdullah, and also the attendees are sending you, big thanks to you for your time spent with us. And of course, we have spent some kilojoules speaking, discussing, presenting. So you have burned some energy already, have done some physical activity with us. Thank you, Doctor. I would like to thank also Oman Neurology Society and for the cooperation. And I think we are waiting for you for the coming Thursday for the second session. We'll send you the registration format through the emails if you have registered your email, or through our social media links through Oman Family Medicine Society and through our WhatsApp group. Any final words, Dr. Abdullah?
No, thank you, Zahir, and thanks for the participants. Excellent questions, very practical, and initiatives like this are always welcome. And definitely a lot of issues related to headaches. Maybe in the future we need to discuss and give it more time. And see you next week, the second lecture by Professor Aaron on common primary headaches, in addition to which we already covered today, migraine.
Yeah, thank you, Dr. Abdullah, and thanks for attendance, and hope you have spent a good time. So, I mean, see you inshallah next week, and we are closing the session with thanks for speaker and attendees. Thank you, Dr. Abdullah.
Okay,
and
thank you.
مع السلامة.
مع السلامة.
مع السلامة.